Hi, I'm Dr. Joya Griffin. I'm a veterinary dermatologist, and I'm here to talk about one of my favorite things, cytology. Thanks for joining me today to talk about cytology. To give you a little background about myself, my name is Dr. Joya Griffin and I'm a veterinary dermatologist. I graduated from Cornell and then went and did a one-year rotating internship in Chicago. And then I returned to Cornell for my residency and actually stayed for a year to teach. And then after that, I joined Animal Dermatology Clinic where I've been since. And I enjoy treating all kinds of skin disease on dogs, cats, horses, and even some of the kind of more exotic creatures like chameleons, snakes, and even some of our zoo species. I went into dermatology because of my own pet, Gizmo, who was our family dog. And when I was in undergrad, she suffered from severe skin disease to the point where she had to live in an e-collar for over a year. So dermatology was something that I didn't know a lot about, but I knew that my dog needed help. And so when I graduated undergrad and went to vet school, I took the dog with me and I went straight to the dermatology service and got her the help that she needed. Being able to see this transformation in her was amazing. It meant so much to me and my family that I decided at that point that I wanted to go into dermatology so that I could make that same transformation for my patients. And it's been something that I've loved ever since. My love for cytology started early on in vet school. I was trained closely beside my mentor who actually gave me a project to do reading slides. So early on, I spent many hours at the scope trying to command this field, and I do cytology on almost every one of my patients. So why do we perform cytology? Well, cytology is the best way to know what you're actually treating. It allows us to choose the most appropriate therapy, and it's easy to do. You get quick results right there while the patient is in the clinic, and it's very inexpensive. Once your eye becomes trained to know what you're seeing, you're able to formulate the best treatment for each of your patients. So with our cytology, we're looking to determine what type of bacteria is present. Are these cocci or are they rods? Are we seeing yeast or a type of dermatophyte or ringworm? Or are you seeing some other kind of unusual fungal element? You also are looking for inflammatory cells because that can tell you the difference between something that's a sterile process versus an actual infection. And then you can also sometimes see neoplastic cells, which is really important because then you know that that guides your treatment and maybe you need to proceed with biopsy and histopathology. Also, if we're seeing inflammatory infiltrates that don't quite fit with what we think clinically is our diagnosis, they'll help to lead you in the right path. So next, I'm going to go into each of the different cases that we can best utilize our cytology for. And one of the main ones that we use it for is Malassezia. Malassezia is a type of fungus, and as you know, this can cause a lot of different changes to the skin because it's often chronic. These are cases that have lichenification. That's where the skin is kind of like elephant skin. The skin will be thickened. You'll see exaggeration of the normal lines and texture to the skin. The skin can also be very hyperpigmented. And these are the dogs that you sometimes smell before you actually see them because the odor is quite, it's kind of a specific odor that some people will say that they can smell. Thankfully, being in this career for many years, I feel that I've become a little bit nose blind, so I don't always notice the awful smells that come into the clinic unless they're really, really severe. Another thing that you can see with Malassezia is that these dogs will have a lot of seborrhea, so their skin can either be greasy or they can have a lot of scaling on the skin. They can also be a little waxy, and so these are dogs that the pet parent may say, I bathe them, and then, the very next day, my dog is greasy and smelly again. Another clinical sign of yeast overgrowth on the skin is brown discoloration, which you can actually see as a waxy debris on the claws themselves. And then in the areas that the dog is licking frequently, sometimes you will also see saliva staining. Saliva staining is not specific for Malassezia, but it's often a feature that we'll see. You can also see saliva staining with bacterial overgrowth on the skin, so that's where cytology is important. There are 3 different sampling techniques you can use in order to determine if your patient has Malassezia. You can use the toothpick technique, which is fairly new to most people. You can also do a tape prep, or you can do direct cytology, which is what I usually do. But in some areas, especially in areas of deep skin folds or other intertriginous areas, those are areas where the skin folds and rubs on itself, tape prepping is very useful in those areas. And then also using the toothpick technique is helpful for removing yeast in areas around the claw bed. They found that there are significantly higher amounts of malassezia and cocci with the toothpick technique. So you can keep those in your clinic. They're very useful and free, essentially. Malassezia look like classic peanut or footprint-shaped budded yeast. They are approximately 3 to 5 micrometers, and they often adhere to keratinocytes, but you can see them free on cytology as well. And the number of malassezia that are abnormal really varies by location that's sampled. So if you're sampling an area of folded skin or an area in between the toes on the feet, it's okay to see a few yeast. They have found in studies that it's abnormal if you have greater than 5 yeast per oil immersion field, if it's in an area where inflammation is present. I'm always asked what number of yeast is appropriate, and it really depends on the area that you're sampling. If you're sampling an area of folded skin or an intertriginous area, then those areas sometimes will naturally just have higher numbers of yeast. They've found that it's abnormal if you have greater than 5 yeast per oil immersion field, or 1 yeast if inflammation is present. So you always have to take into consideration the areas that you're sampling and the clinical effects that the patient may be having. So if this is a basset hounds have yeast. So I don't worry about it if I'm doing cytology on a basset and they have yeast in the ears in small numbers, maybe a few per field, but the dog does not have any symptoms of otitis. I wouldn't necessarily chase those few yeast. But if it's an area that is very inflamed and you've got debris and you have a patient that's licking a certain area and you find the yeast that's there, those yeast could be clinically significant. We also know that occasionally you will do cytology and not see any yeast in a patient that appears to have a yeast dermatitis. And sometimes in those cases we do treat with a trial of an antifungal or topical antifungals to try to rule out whether or not malassezia was playing a role in their clinical signs and their pruritus. Determining the type of treatment that you use for malassezia dermatitis or even otitis really depends on the severity. If it's focal, you could try topical therapy, and there are many that are out there. Chlorhexidine at 3 to 4% is effective against yeast, or you can use the azoles topically to treat those types of infections. If you're having an infection that's more generalized, then you may want to add on systemic therapy in addition to your topical therapy. And this includes our azoles like ketoconazole and fluconazole, as well as terbinafine. There is some thought that there could be some resistance with malassezia, and in those cases, we will often try different classes of antifungals if our typical ketoconazole is not effective. If these patients are greasy, which they often are, I go to antiseborrheic shampoos. These often contain salicylic acid or benzoyl peroxide to help to remove that grease. Utilizing antiseborrheic topicals and shampoos are very useful in removing the greasiness that these patients often have. Diagnosing staphylococcal infections is probably one of the primary reasons why I utilize cytology in my practice. These are cases that present to you with papules, pustules, crusts, and even epidermal collarettes. An epidermal collarette is actually the footprint of a previous pustule. It's a little rim of crust that you'll see often with an erythematous center. And when you see these cases that present like this, the obvious thing is to think that staph or another type of bacterial infection is present. But in some cases, these lesions can actually be present with sterile dermatoses. Things like pemphigus or even lupus can sometimes present with lesions that mimic other bacterial infections. So we also will see in short-coated dogs a moth-eaten appearance where they have kind of patchy hair loss. In some cases you can see moist dermatitis, which is the typical pyotraumatic lesion that a dog will actually induce itself. And these lesions are very eroded and they're kind of sticky. And then of course with bacterial infections, these dogs often have an odor, and the pet parent will tell you about it. There are several different ways in which you can collect samples in determining if your patient has a staphylococcal infection. One of the most common ways is by direct impression, but there are a couple different ways that you can collect these samples. One would be through the scrape and smear technique. That's where you actually use the glass slide to lift up the edge of the epidermal collarette or the crust itself, and then you would stain that debris that's on that slide. You can also do the pluck and squeeze technique. This is really important for areas in between the digits where the skin is really inflamed and swollen. You can actually perform this by plucking the hair in those areas and squeezing the skin really firmly, and then getting your slide and putting it to the exudate that comes on the skin at that point. You can also do a superficial skin scrape. This has also been referred to as the bread and butter technique, which I really resent because that's gross. But the superficial skin scrape you can do by using the slide to kind of, like you would butter up a piece of bread, kind of grab up your material and look at the material on the slide that way. Once you stain your slide using Diffwick, you can then determine what's present on the slide. If you're seeing cocci, these are most commonly Staph pseudointermedius, and they're often in pairs or tetrads, and they're a normal inhabitant of the skin. So I don't necessarily worry about these if they're free cocci, but if you're seeing intracellular cocci and numerous degenerative neutrophils and nuclear streaming, then that is the hallmark of an actual true infection. You can also see on your cytology rods, these are most commonly Pseudomonas, and this also represents an opportunistic infection. There can also be Proteus or E. coli. Those also occur in cases where you'll see rods on cytology. If you are wanting to know specifically the best antibiotic to treat, the only way to know specifically what type of bacteria are present is to culture. The shape of the bacteria just give us an idea, but the culturing would let us know for sure. Treating staph infections or other bacterial infections on the skin really depend on what you're seeing, the extent and severity of the lesions. If the lesions are focal, topical therapy may be enough. And we're really moving away from treating everything with antibiotics. Through antimicrobial stewardship, we are using systemic antibiotics less and less, and I'm finding that patients will still do very well with even just topical therapy. The most important thing is to choose the right topical therapy. So if you are suspecting a staphylococcal infection, using a chlorhexidine-based shampoo, spray, or mousse is very effective in reducing the bacterial overgrowth and bacterial infection on the skin. I typically choose a 3 to 4% chlorhexidine or a combination product such as one with 2% chlorhexidine and 2% miconazole. Systemic therapy is often chosen if we have more widespread infection or if topical therapy cannot be done effectively. And we're going to choose cephalosporins as our first line of treatment. But of course, if these cases are not improving, it's very important to know when and where to culture. And culturing is definitely the best way to find out which antibiotic you need to use. And let's briefly talk a little bit about otitis, specifically Pseudomonas cases. These are cases that you often smell before you actually walk into the exam room. It has a very strong, malodorous, putrid smell actually. And these are cases that are often suffering with a lot of pain. They have thick purulent debris within their ear canals. They have ulcerations along the ear canal. And they're often cases that have suffered from chronic otitis for many months to years. When you perform cytology on these cases, you essentially are collecting the sample with a sterile Q-tip, going down into that ear canal as far as you can, and collecting that debris. And once we smear that out on a slide and look at that under the microscope, you're going to see rods and rods and rods. And of course, many of these are going to be intracellular, indicating that a true infection is present. Another way to collect cytology in these painful Pseudomonas ears is to use a red rubber catheter. You use this because it's a little more flexible and less rigid than a cotton-tipped applicator, and you can insert that down into the ear canal, aspirate using a syringe, and then sample that material from the end of the red rubber catheter. Pseudomonas, of course, are rod-shaped. They are approximately 0.3 to 0.8 micrometers, and most of the time when you see these rods, it's often going to be Pseudomonas aeruginosa is the most common type of bacteria, but you may also see other rods like Proteus or E. coli. Rods found in the ears are not normal. Whenever found on cytology, you must suspect that an overgrowth is present or that an infection is there. They're always significant when they're found, especially if inflammatory cells are there. And nuclear streaming can also be seen, which indicates degenerative cells that are working to clean up all of this bacteria. Culture and susceptibility is often performed on otitis cases, and I can tell you that it's somewhat controversial, even amongst dermatologists. So this is something that is utilized by some and not utilized by others. But the reasons to do culture in these cases is if you're seeing a mixed infection in which rods are present, whenever you see large numbers of white blood cells with little evidence of bacteria, or if this case is failing to respond to previous therapy. So if this is a dog that's presented to you after having been through multiple rounds of antibiotics, topically or systemically, this is a case that culture could be very effective. Culture is also indicated for cases whenever you think that otitis media is suspected, and in Pseudomonas that often is the case, especially if it's chronic. And it helps us to best choose the systemic antibiotics that we want to use. If you're just choosing topical therapy, culture may not be super necessary, but it can definitely be a good thing to do if you're going to start systemic antibiotics because of an otitis media case. Whenever rods are seen on cytology, consider basing your treatment on culture. This can help you choose your topical therapy and systemic therapy if ulcerations are present within the external canal, or if you suspect otitis media and other middle ear disease, or if there's osteomyelitis of the bulla. Treating Pseudomonas otitis is definitely challenging, and in these cases, doing a deep ear flush under sedation is often useful because it can get all of that material out of deep within the horizontal canal while the patient is sedated. It can also allow you to see if middle ear disease is present. In cases where you suspect middle ear disease, culture can be very useful because it helps you tailor the best systemic therapy for that patient. Topical therapy is also utilized in all of these cases, and together, topical and the systemic therapy are the best way to help get a handle on this type of infection. So far, we've talked about inflammatory lesions on the skin that are infectious, but some of these lesions that we see that we think are bacterial or yeast in nature can actually be due to autoimmune diseases. One of the most common types of autoimmune skin disease that exists is pemphigus foliaceus, or superficial pemphigus. This type of autoimmune disease can have features of ulcerations and crusting that can begin on the dorsal muzzle, but then it can extend to the nasal planum. You can also get nasal depigmentation, and they have this classic honey-colored crust, which is really important because that should always cue you in that this might not be a bacterial infection and that it could be something else. These cases often have pustules, though the pustules are very transient, and so you may not see those. And then they can get crusting that's on the paw pads, and the crusting can be quite prominent and severe. Any case of pyoderma that is not responding to typical therapy and persists despite empirical choices of antibiotics or even culture should be a suspicious case for pemphigus or other autoimmune diseases. In sampling these refractory cases that mimic other bacterial and yeast diseases, I will sample them just like I would any other pustular or crusted disease. If a pustule is present, I will take a sterile needle and rupture that pustule and then do a direct impression smear of that material. Or if you have a crusted area, I will use the edge of a slide to lift up the crust and collect the sample that way. When you do these samples, what you're looking for is a fairly sterile process. So there will be neutrophils present, but the neutrophils are fairly healthy. And in some cases, you can see eosinophils in small numbers, but I have seen cases with many eosinophils with pemphigus. You will also see a classic sign that is telltale for pemphigus, and that's the acantholytic keratinocyte. These are large, round basophilic cells. They have a fried egg appearance, and they have a central basophilic nucleus. So when you see these, you have a very high index of suspicion that this could be pemphigus, and biopsy is indicated at that point. And what about our frisky felines? Cats are not small dogs, so even with pemphigus, they present a little bit differently than the dog. When the dog has pemphigus, the lesions typically start on the face, though they can spread to other parts of the body. And dogs are fairly simple. They'll have transient pustules, honey-colored crusts, But with cats, they're more commonly, the lesions are on the ears and on the claw folds and then around the mammary glands. And I always joke and say that this is perinippelar crusting. So if you're seeing crusting around the nipples on a cat, pemphigus should be on your differential list. They will occasionally have lesions on the nasal planum, but it's much less common than with the dog. Treatment for pemphigus really relies on immunosuppression, so it's important to have a true diagnosis. Cytology can help guide you in that diagnosis, but a definitive diagnosis would really rely on histopathology. Once you have your diagnosis, cases are often treated with steroids or a combination of steroids and other immunosuppressive medications like azathioprine, cyclosporin, and mycophenolate. We're also starting to use oclacitinib for treatment of these cases, and I have found that multimodal combo treatment is more successful than monotherapy with steroids in my cases. I have seen too many side effects with high-dose steroids and feel that we have a better balance when you use steroids in combination with another immunosuppressive medication. Topicals are often utilized to help treat any secondary infections and to restore the barrier function of the skin, which is important in most of my dermatologic conditions that I treat. Dermatophytosis is considered the great imitator because the signs and symptoms can highly vary dependent on the host-fungus interaction. So some animals can be quite inflammatory, they can even be pruritic, and others may have really very little evidence of carrying dermatophytosis. So trying to diagnose this can sometimes be tricky. Cytology can be used to help us, and in some cases you may be lucky to actually find the fungal hyphae. In my patients, trichography, or performing a trichogram, is very useful in determining if the hairs are infected with arthroconidia or fungal hyphae, and it's a really simple way to do a diagnosis in your clinic. Trichography is a very useful tool to help you look at the integrity of the hairs in these alopecia or crusty areas that you might find on a dog or a cat. Trichography is simply done by plucking hairs from an affected area. You can actually use a Woods lamp to guide you, but as we know, Woods lamp only fluoresces in up to 50% of M. canis cases, so it may be negative and it does not rule out ringworm. So in these cases where you have lesions that are present, you pluck from the edge of these crusted alopecic areas, and then you want to put them under mineral oil and look at them under the microscope. You want to look and determine if there's normal architecture of the hairs, if the corticomedullary distinction is present. And in hairs that are infected by fungi, that corticomedullary distinction is lost, and you'll often find arthroconidia or fungal hyphae running along the hair shaft. In some cases, you'll just see hairs that appear a little roughened and they have loss of that corticomedullary distinction. In these cases, we will then go forward with trying to confirm dermatophytosis with fungal PCR and with fungal culture. Dermatophytosis is often present on the face or the muzzle, and this often is because of how the patient contracted the ringworm. So as we know with trichophyton, this is often something that they get from the soil, rooting around or digging into the soil. Fungal carrions are an interesting kind of lesion because they can mimic tumors on the skin. They have a very histiocytoma type look. So these are erythematous, very swollen annular lesions. They're often present on the muzzle or on a distal limb, and they're often confused with other types of lesions. These lesions on these patients will often spread in a centrifugal way, and there sometimes is a history of contagion. So there are owners who have lesions as well as other patients in the home, other pets that live with the affected patient having lesions. There are several different tools that we can use to determine if a patient has dermatophytosis. One is through Woods lamp examination, and with this we're looking for fluorescence of the hairs with a specific apple green fluorescent. This can occur in up to 50% of cases of M. canis or microsporum canis, but it's not super effective in catching all the cases, so I wouldn't rely on this test alone. Dermatophyte culture is very useful, and that's probably the primary way that I diagnose my patients with ringworm. We pluck hairs from affected areas along with scale. You can also use a toothbrush technique where you will brush through the animal's fur to plate that material the material in the hairs that you collect. This is fairly useful in trying to determine if a patient in a multi-animal household may be carrying the ringworm but not actually have classic lesions. Dermatophyte PCR is also being utilized, and it's a fast, effective way to diagnose if a patient has ringworm. And you determine this by also collecting hairs and sending those out to a reference laboratory. Trichogram is one of my favorite ways to look for ringworm in-house, because you will pluck hairs from a lesion that's affected and you'll put those under mineral oil and look at those under the microscope to determine if there's normal corticomedullary distinction in the hairs or if you're seeing fungal hyphae or arthrochonidia within those hairs. Dermoscopy is probably a fairly newly utilized tool. It is where you take a specialized magnifying lens to examine the hairs, and you're looking for an abnormal kind of comma-shaped hair that has been seen with cats affected with ringworm. So in a multi-cat household or in catteries or shelters, this is a very inexpensive tool that can help you weed out the affected from the non-affected. Occasionally on cytology, you can actually be lucky in finding fungal spores. They're going to be encapsulated and approximately 2 to 4 micrometers in diameter, and they'll have a capsule or halo around them. You can also see inflammatory cells such as neutrophils and macrophages, as well as nuclear streaming. But this is a pretty lucky find if you're able to find this. It's important to carefully read your fungal cultures. The fungal cultures should be kept in a cool, dry place, and they should be looked at on a daily basis. Best practice is to keep a log and make sure that someone is looking at these daily. Dermatophytes utilize protein first, with alkaline metabolites turning the medium from yellow to red. This color change should occur with the colony growth and should not happen early without colony growth, so they should occur together. Colonies are never green, gray, or brown. So if you're seeing something that looks slimy, grayish, or brown, then it's probably some sort of saprophytic fungus or something that's just in the environment and not a true dermatophytosis. When you do have this nice white fluffy growth, you want to collect that with a sterile needle, usually a 22 gauge, and then you use that needle to kind of tease off this white fluffy growth, which is called a thallus. And you will take that white fluffy growth and smear it out on your slide in a drop of your purple or blue counter stain. And then you can cover that with a cover slip and look at that under the microscope so you can actually determine what type of dermatophyte you're dealing with. This is really important just so that you know where the animal may have gotten the infection from, but it doesn't really change our treatment. Treatment is really tailored to each individual patient. If it's focal, you may be successful with just topical therapy, but whenever these lesions are more widespread, systemic therapy with an azole or terbinafine is really important. I often utilize a 3 to 4% chlorhexidine shampoo with my dermatophytosis cases, but you can also use shampoos that contain the azoles like miconazole or ketoconazole. Another type of bacterial infection that you may find on cytology is mycobacteria. This is a fairly rare disease, but the dog may present with single or multiple ulcers on the skin, or they can have abscesses or draining tracts, and they're often on the ventrum, especially in cats. These cases can also present with plaques or nodules, so cytology can be a useful tool in trying to diagnose what's going on with these cases. What I have found useful is to use a needle and actually aspirate in these lesions and to extract some of the fluid that is present in these ulcers. When I'm trying to determine if a case has mycobacteria, aspiration is often done. Aspiration is a useful tool in performing cytology with suspected cases of mycobacteria. Mycobacteria are clear, non-staining rods, so you need special stains to actually see these on cytology, and acid-fast stains are often utilized. Epitheliotropic lymphoma is one of the most common types of cutaneous cancer that I see. These are cases that present with exfoliated erythroderma. This is where they have scaling that's fairly widespread, or even just extensive redness to the skin. They can have patches or plaques on the skin, and then with time, these plaques and patches can turn to tumors or nodules in the skin. These cases most often have depigmentation of the mucocutaneous junctions, and they can have kind of a long history of these lesions before they come in to see me. These dogs are often very pruritic, and in order to diagnose them, biopsy is often necessary, but you may get lucky in doing an aspirate of these nodules or tumors that are present and identifying the cancer cells or lymphocytes. Impression smear can be done as well, where you'll take a sample from the erosive or scaly lesions, and in some cases you can identify large numbers of lymphocytes. So that's the basics of cytology. Feel free to follow me on LinkedIn or on Instagram, or check me out on my website, drjoyadvm.com. Thanks for watching.